I want to speak about cancer of the pancreas. And cancer of the pancreas is maybe divided into some categories. We have primary cancer of the pancreas, which is the exocrine pancreatic cancer, and that represents about 95% of cases. 2% of cases are neuroendocrine tumors. 2% are metastatic cancer to the pancreas from another organ, and the rest are rare and very rare tumors like lymphoma and sarcoma. Pancreatic cancer is the 9th most common cancer in the United States, and it's the 4th cancer-killing disease in the United States. It is the 6th in Europe, and it kills about 200,000 people annually worldwide. This cancer is an epithelial cancer, and it is mostly located in the head and neck, which is about 75%. 10% is in the body of the pancreas. 15% is in the tail, and the rest involves the whole organ. And there are specific risk factors. Some of them are associated with low risk, some are associated with moderate risk, and some are associated with high risk. These factors include obesity, diabetes. They include some genetic diseases like BRCA1 mutations, BRCA2, Busch-Jaeger disease, the melanoma disease, and mole syndrome, hereditary non-polyposis colorectal cancer, and chronic pancreatitis, cystic fibrosis, and family history of pancreatic cancer. The symptoms of pancreatic cancer, whether it's in the head of the pancreas or in the body and tail, are very similar. And these are constitutional symptoms like loss of weight and weakness, and non-specific upper gastrointestinal symptoms like nausea, vomiting, and abdominal pain. The only remarkable difference between these two sites in the organ is the jaundice is very common in the head of the pancreas and is rare in the body and tail of pancreas cancer for obvious reasons, because the tumor obstructs the common bile duct where it's next to it in its vicinity. If there is jaundice in a patient who has cancer of the body and the tail, it's either because he has extensive metastatic disease in the liver, or because he has portal lymphadenopathy that is causing obstruction of the common bile duct. When we have patients suspected with pancreatic cancer, we do the routine investigations. And we do serum carbohydrate antigen 19-9, which is an antigen that is secreted by pancreatic cancer. And the imaging, standard imaging test is a CT scan of the abdomen, but an MRI and endoscopy are also helpful. And ultrasound. Endoscopic ultrasound, it can tell us about the size of the tumor as well, and its consistency, and the presence of lymph nodes, and the status of the portal vein. In addition to these, we usually do laparoscopy for staging and before we embark on the operation. Laparoscopy will show us very small metastases like subcentimetric metastases in the peritoneum or in the lymph nodes that may not be seen on CT scan. And it will also give us the opportunity to do an endoscopic ultrasound, to do biopsy, and to do fluid collection for cytology. But laparoscopy is difficult when you are visualizing a retroperitoneal structure. There is also a very low but real risk of port site metastasis, especially if we handle the cancer tissue during the laparoscopy. Now, the carbohydrate antigen has about 80%, around 80% specificity and sensitivity, and it correlates with the resectability. So when it's very high, it's more likely to be unresectable. And this correlation is even stronger in the body and tail of the pancreas than in the head of the pancreas. And we have to remember that carbohydrate antigen 19.9 is secreted by other malignancies of the pancreas and the liver, gynecological and gastrointestinal malignancies, and also in some benign conditions like cholangitis and cirrhosis. The staging of pancreatic cancer is based on the TNM classification, which is developed by the American Joint Committee on Cancer. The T is for the tumor size from 1 to 3, and above and below 2 and 4 centimeters. And the N is for lymph nodes, and M is for metastasis. And stage 1 is usually T1, T2 lesions, and stage 2 is a T3 lesions or T1 and T2 with an N1 disease. Stage 3 is a T4, which is any size of the lesion, but with the major vessels being involved. Or stage 3 can be an earlier T lesion, but with N2 status, which means more than 3 lymph nodes are involved. And then stage 4 is metastasis. The staging correlates very well with prognosis, as stage 1 have 5-year survival of about 40%, while stage 3 has 5-year survival of about 10%. The surgeons usually divide pancreatic cancer based on its resectability into resectable, which means that there is no extrapancreatic disease and there is no metastasis, and there is a clear fat planes between the tumor and the major blood vessels. And then we have borderline resectable, which means there is also no metastasis, but there is a partial involvement of blood vessels like superior mesenteric vein and superior mesenteric artery, but not exceeding more than 180 degrees of the circumference of the wall of the blood vessel. And then we have unresectable, which means either it's metastatic or it is involving vital structures like the IVC or the aorta, or if it is encasing the celiac artery and superior mesenteric artery in a way that is unreconstructible. We can predict from the CT scan the vascular invasion based on how much or what percentage of the circumference of the wall of the blood vessel is contiguous with the tumor, from 25% to 100%. And the higher the percentage of the circumference of the blood vessel wall, the more likely the invasion is there. So if there's no contiguity or the contiguity is less than 25%, chances are there is no invasion. If it's more than 50%, there is about 50% chance of invasion. And if it's 75%, there is about 80% chance of invasion. And if it is more than 75%, almost all these cases have vascular invasion. Another issue is also to look at how high or low the involvement of the superior mesenteric vein, because if it is lower than the inferior border of the duodenum, that makes it more unresectable. The veins are usually, if there is a partial involvement, the tumor is wedged out from the vein, and the patch of an internal jugular vein is used to close the defect. If the defect is through the whole vein, then it has to be resected, and then end-to-end anastomosis would be performed. And if the segment is long, then you may need to interpose an internal jugular vein graft between the superior mesenteric vein and the portal vein. One controversial issue is the preparation of patients for surgery. Patients should have antibiotics prophylactically, anticoagulants, and they should have immunization against encapsulated bacteria if splenectomy is contemplated. The preoperative biliary drainage is controversial. But these patients have coagulopathy sometimes and malnutrition. And although there is no significant difference in outcome between those that you drain and those that you don't drain, one study has shown that stenting is associated with more postoperative complications, especially infections and a longer hospital stay. But usually we will do preoperative biliary draining selectively. Those patients who are symptomatic, those who have significant hyperbilirubinemia, and those who will undergo neoadjuvant chemotherapy. The treatment for borderline resectable or locally advanced, non-metastatic or unresectable is to give them chemotherapy, restage them, give them again another cycle of chemotherapy or radiotherapy, restage them, and then reassess them, and possibly some of them will, their tumor will shrink and they will be suitable for surgery. The operation is a standard pancreatic duodenectomy described by Whipple, which means you remove the distal stomach, duodenum and proximal jejunum and the common bile duct, with the head of the pancreas, of course. If the patient has body and tail of the pancreas cancer, then you do a distal pancreatectomy with a splenectomy. And also lymph nodes around the area of the neck and tail of the pancreas must be part of the specimen. And if when you are doing the pancreatic duodenectomy, the lymph nodes around the major vessels and the biliary tree should be excised. But the Japanese advocation of extended or radical lymphadenectomy, in which the para-aortic lymph nodes are also involved, is not widely accepted and doesn't seem to have an impact on survival. After the operation is done, then you have to do 3 anastomoses, which is stomach to, you bring up on Y jejunal loop, and you anastomose it to the common hepatic duct and to the stump of the pancreas and to the stomach. And the stump of the pancreas can be stitched either in 2 layers, mucosa to duct and then serosa to the outer layer of the pancreas, or the pancreatic stump may be invaginated in the lumen and then closed with the stitching around it. And this may be done in an end-to-end or end-to-side manner. Complications, well, there is a mortality of about 1% in highly specialized center, and you can have post-operative intra-abdominal abscess, wound infection, hemorrhage, and post-operative leak, especially pancreatic leak, and of course recurrence as well. And the recurrence usually occurs in the first 3 years, and it's most commonly in the liver and in the tumor bed area. Thank you.